Hello and welcome to today's Let's Talk About Health webinar. My name is David and I will be in the background answering any WebEx technical questions. If you experience technical difficulty at any time during this event, please submit your technical issue in the Q&A panel and I will assist you. Please note that as an attendee, you're part of a larger audience today. However, due to privacy concerns, the attendee list is not displayed. All attendees will be in a listen-only mode for the duration of today's call, and as a reminder, this call is being recorded. We will be holding a Q&A session at the conclusion of today's presentation. We encourage you to submit written questions at any time during the presentation using the Q&A panel at the bottom right of your screen. Just type your question into the text field and hit send, and please keep the drop-down as all panelists. I'd like to introduce your first speaker for today, Donna Jacobs. Donna, you now have the floor.
Thank you so much, David. Hello, everyone, and good afternoon. I want to welcome you to Let's Talk About Health, a community conversation series about important health topics and health-related issues. I am Senior Vice President at the University of Maryland Medical System, and we're glad to have you join us today. I will be your moderator. Our Let's Talk About Health series is designed to increase awareness about important health topics, give people tools to help them stay safe and well, and in many cases, improve patient and provider communication. To that end, parts of this conversation are framed to help people get resources and better engage in conversations with their providers, and I'll share more on that in just a moment. The University of Maryland Medical System conducts a community health conversation in this virtual format every month, every third Wednesday at noon, so people can participate, join us during their lunch hour. Our topic today is intimate partner violence, as we of course recognize IPV, or domestic violence as it's sometimes termed, in the month of October. Leading our conversation today is Erin Walton. Erin is a licensed clinical social worker and the program manager of the Violence Prevention Program at the R. Adams Cowley Shock Trauma Center at the University of Maryland Medical Center. She specializes in clinical mental health and trauma, violence prevention, and community organization. She is double degreed from the USM system, having received her Bachelor of Science in Psychology and Family Studies from the University of Maryland College Park, and her Master's in Social Work from the University of Maryland School of Social Work in Baltimore. Her expertise includes crisis intervention, play therapy, mental health first aid, and motivational interviewing. Erin is someone whom I admire greatly. She's knowledgeable, quite capable, and passionate about her work and helping others. This conversation is meant to be just that, and we want you to ask your questions as David mentioned. So please do feel free to use the Q&A panel to type in questions that may occur to you as she is speaking. And when she concludes, she'll be happy to address as many of those questions as time allows. Let me say at the outset that Erin's slides will be available to you in a few days. I'll share more on that later, so you won't have to rush through and take notes unless you choose to. And triggers. The content of today's presentation deals with many issues that people may find distressing. And while of course it's not our intent to create any extra stress on the part of anyone, this content and this conversation are of vital importance, and we want to be able to talk with you. If at any time you feel overwhelmed, or memories of your own past or occurrences that are current trigger in a way that is distressing, please feel free to take a break for whatever period you may like and then rejoin us as you wish. Or alternatively, we have counselors standing by from the Bridge program, which is the domestic violence program at the Trauma Center here at the University of Maryland Medical Center, and you may call them offline. They are standing by to take your call if you would like to speak to someone, and that number is there on the screen. And for those who are listening, it is 410-328-2425. That number will appear across the bottom of the screen at several points during Ms. Walton's comments. And with that, Erin, let me turn to you. Thank you. Oh, there's one more thing. One more thing that I'd like to do. I did mention that I would talk about some tools that may be helpful when you want to communicate with the provider. And we call it Ask Me 3. And this is really a way for you to take charge. There are 3 questions to keep in mind when you are talking to a healthcare professional or when you're trying to get information generally. What is my problem? What is the main issue that I may be experiencing? What do you call it? What is it? What do I need to do about it? And why is that important for me to do? So 3 questions. What's the problem? What do I need to do? And why is it important for me to do this? And toward the end, Erin will give you an example of how that might apply in this situation. Now, Erin, thank you.
Thanks, Donna. Thanks for that lovely introduction. And I'm really happy to be here. I've been able to be a participant in these and background support on these. And so I'm really honored to be able to speak about this issue. And what I hope to do today is help everybody understand why we're talking about intimate partner violence in the context of health and healthcare. And then answer any questions that you might have about how it's impacting you or your health or how your healthcare provider might be able to help you. So, like many other diseases that you might discuss with your healthcare provider, intimate partner violence is a serious and preventable public health problem, and it affects millions of Americans. The term intimate partner violence, which you may also hear interchangeably used with another term, domestic violence, describes physical violence, sexual violence, stalking, or psychological harm by a current or former partner or spouse. And this type of violence can occur among heterosexual or same-sex couples and does not require sexual intimacy. And so the reason that I'm mentioning that is because there is a difference between intimate partner violence, family violence, child abuse, and there are resources and experts in all of these different types of violence. And today we're specifically going to focus on the type of violence or abuse that occurs between 2 people that are intimately involved in some sort of dating, romantic, or cohabitating, or possibly co-parenting relationship. So, like I just mentioned, intimate partner violence occurs between people who are or were involved in an intimate dating or romantic relationship. So this could mean that you've ended a relationship, but the type of abuse that you're still subject to is considered intimate partner violence because the person who is abusing you was at one time an intimate partner. It could refer to one incident of abuse or chronic and varied types of abuse over a long period of time and includes the time after the relationship has ended. Physical violence, which is one reason that people seek health care or treatment in a healthcare facility, can include assault, which is, for example, hitting, kicking, strangling, restraining, or other types of physical force used against a person's body. Sexual violence can mean rape or attempted rape, sexual assault, or any non-consensual sexual act or contact. So not necessarily physical, but can be. And then stalking includes a pattern of ongoing unwanted attention and contact that leads to fear for one's safety or the safety of others close to them. Psychological harm is caused by aggressive verbal and nonverbal communication that causes harm through mental or emotional abuse or control. So any of the things that I just mentioned could even stand alone, a one-time incident of any of the things that I just mentioned could be considered intimate partner violence. And all of these things could lead to serious health issues or death. However, like many healthcare issues, violence can be prevented, and there is help and there are resources available, which you can learn about by talking with a healthcare provider. So some facts about intimate partner violence. Intimate partner violence can cause serious health and social issues for people. Physical injury, isolation, financial instability, depression, and other mental health issues like PTSD are common. People who experience violence are also at risk for developing a substance use issue. The stress related to any one of the issues that I mentioned in the last slide could be enough to lead someone to seek medical treatment, as they may suffer from weight loss or weight gain, trouble sleeping, panic attacks, or other symptoms of acute stress. And If you were to seek help from a healthcare provider for any of those issues, the healthcare provider will ask you about your safety in your home and try to determine whether intimate partner violence is related to any of your health issues, and if there are safety concerns present. Preventing intimate partner violence means knowing and promoting the characteristics of a healthy, respectful, and safe relationship in schools, families, individuals, and communities. And talking about intimate partner violence in forums like this, in the community, in schools, and with your healthcare provider, talking about the consequences of intimate partner violence, the harm that it does, and also the resources that are available can help to shed light on the issue and help people feel more safe to speak up and ask for help if they are affected by the issue. So violence, and in particular domestic or intimate partner violence, is relatively newly recognized as an issue for the medical field. It wasn't until 1985 that the US Surgeon General at the time, C. Everett Koop, presented interpersonal violence as a public health issue, separate from an issue of criminal justice or community welfare. And since that time, professional medical organizations, healthcare systems, and regulatory bodies have made recommendations and policies about how to best identify and treat issues related to intimate partner violence in a healthcare setting. Hospitals and doctors' offices serve as pivotal places for screening and intervention, as people go to the doctor and the hospital for many reasons, might not be related to a physical injury from an assault, for example. Um, a physical injury due to an assault may be a more severe type of presentation of intimate partner violence that could lead somebody to seek treatment in an emergency department or a trauma center. But there are many other areas where intimate partner violence intersects with healthcare. And recognizing the prevalence of abuse among particularly pregnant and perinatal women, the American College of Obstetrics and Gynecologists was one of the first professional organizations to formally educate its members about domestic violence. Over the course of a person's pregnancy, labor and delivery, and their postnatal care, a person has many visits to many different types of healthcare providers and facilities. And so it offers them many opportunities to interface with medical professionals in inpatient and outpatient settings, where they are able to build trust with those healthcare providers and potentially disclose concerns for abuse that may not include physical violence. This is also an opportune time for disclosure because we know that pregnancy creates additional risk in already abusive relationships. So pregnancy is a very high risk time for people who are in relationships with abusive tendencies. So over the past 40 years since violence was first presented to the healthcare field as a healthcare issue, hospitals specifically have worked hard to evolve their understanding of intimate partner violence as a healthcare issue and how to address it. Intimate partner violence accounts for a large number of injuries, and which lead people oftentimes to seek emergency medical care. It's also one of the more straightforward presentations or documentations of intimate partner violence, where if somebody has a physical, visible injury that they disclose is related to intimate partner violence, that can be tracked, because a lot of what happens with intimate partner violence isn't reported and there's no way to track it. So we have difficulty with having really accurate numbers to say how many people this is affecting. According to the CDC, 35% of female survivors of intimate partner violence and 11% of male survivors of intimate partner violence have sustained a physical injury related to abuse. And as we talked about earlier, while this is only one type of abusive behavior that somebody could be experiencing, it's usually more obvious, especially in a healthcare setting. And it provides an opportunity for healthcare workers to screen for other types of abuse, educate about other types of abuse, and offer help. So since 2004, the Joint Commission on Accreditation of Healthcare Organizations has had standards in place to guide hospitals on how to address domestic abuse through policies on screening and education for staff. And in 2010, here in Maryland, Governor O'Malley signed the Maryland Domestic Violence Healthcare Screening and Response Initiative. which serve to increase the number of specialized domestic violence programs available, specifically in hospital settings, like the one that is part of our program here at Shock Trauma. And this initiative that Governor O'Malley signed also provided support through technical assistance and training to hospitals who wanted to start programs like this. And I'll tell you more if you are interested in, if you have a hospital-based program where you work or where you seek healthcare, if you're interested in starting one, I'll give you a little bit more information about that at the end as well. The American College of Emergency Physicians, the U.S. Preventative Services Task Force, and the Institute of Medicine all require or encourage some level of education for providers and screening of patients. Screening for and intervening in intimate partner violence is an important area of prevention, as IPV can and does lead to death. 1 in 5 homicide victims are killed by an intimate partner, and more than 50% of female homicide victims are killed by a current or former partner. And so that's why I really wanted to underscore earlier in the presentation that intimate partner violence doesn't end when the relationship ends automatically. People are still very at risk to injury and homicide, especially because ending an abusive relationship creates a high risk environment for the victim. So, in determining the best way for hospitals to play a part in reducing homicides due to intimate partner violence through screening for risk factors, a lot of research has been done into the efficacy of different screening tools that can be used with specific or generalized populations. So a screening tool, and this is for any disease or healthcare issue, is something that you use to look for a condition before it is overly symptomatic. So I described before the number of people that come to the hospital or to a healthcare facility seeking treatment for a physical injury. That's a very severe presentation. That is what we would be calling overly symptomatic. We want to be screening before the person becomes overly symptomatic. If they're coming for help because of a currently abusive relationship, we can still screen for other areas of abuse and use that as an opportunity to educate. And so it's for that reason that it is recommended that every patient be screened whenever possible. So we don't determine who gets screened based on their gender, their age, their relationship status, or any other factor. Universal screening is the best practice when it comes to intimate partner violence. There are a couple of validated, really great tools for doing this effectively in healthcare settings that I'm going to show you. And is it on the next? Oops, hold on. Sorry. I do have the tool, it's coming. I forgot about this slide. So like I said, universal screening is recommended across settings, and the best practice for doing this is privately. So the healthcare provider is alone with the patient, and if needed, a professional interpreter, not a family member or partner, if the person speaks additional languages besides English and prefer to communicate in those languages, and using a validated tool, which I will show you. In order to comply with IPV screening requirements in hospitals and in order to contribute to improved health outcomes for patients, it's recommended that healthcare providers familiarize themselves with the tools that are used in their facility. So for example, here at University of Maryland, there's a screening tool that is a flow sheet that's included in every patient's chart when they come to the hospital. And it screens for abuse indicators. And then if the person screens positive for the abuse indicators and it's determined that the abuse indicators are due to intimate partner violence, then the Bridge program, which is the 24-hour intimate partner violence program here at University of Maryland, is called to come and speak to the patient. So there is a screening tool in place and then a protocol for what to do if the person screens positive. So it's recommended that if you're a healthcare provider, you find out what that tool is used in the facility where you work, and know what to do if you use the tool and then the person says, you know, screens positive. If you are a person who's seeking healthcare treatment and you are being asked these questions, then what's important for you to know is that your healthcare provider is asking everybody, and likely asking everybody every time that they see them. And so the tool is in place to improve safety for you and everybody else that's seen in that practice. So let's see. So like I said, if they screen positive here, they're referred to the hospital-based intimate partner violence program. In an informal survey conducted of 8 hospital-based programs here in Maryland, responses to that survey showed that about 2,700 victims of intimate partner violence received screening and intervention when they were seen at the hospital. And so of those, 36% of those people that screened positive in that intimate partner violence screening, 36% of them were in the hospital for reasons other than assault. So they came to the hospital for some reason not connected to the abuse in their relationship, but because they were screened, they were able to disclose to a trusted healthcare provider and then get help or intervention or services or resources. So just like any other healthcare screening, what that tells us is that we are able to effectively screen for otherwise undetectable risk factors in a person and help intervene before those risk factors become more dangerous. So of the 36% of people that were here for reasons other than assault and screened positive, 85% of them learned of new resources because of that visit and that screening. So if there had not been a hospital-based domestic violence prevention program in place at their visit, then they might have missed out on the opportunity to improve their health care outcomes through improved safety in their relationship. If you are a healthcare provider and you're in a setting where you're asking questions about these screenings, resources, programs, and you're not finding resources quickly available to you, you should find out what your local domestic violence resource center is in the community and reach out to them to learn about referral options. So here's the screening, one of the screening tools that I mentioned. This one's called the HITS, which stands for Hurt, Insult, Threaten, and Scream. In 2012, there was a systematic review done to publish the most effective tools that can be used in healthcare settings in order to screen for intimate partner violence. And this was found to be one of the most effective tools. This tool is effective with people who both do and do not have visible injuries or a known history of intimate partner violence. So it's able to uncover new information about people's relationships that may be creating risk factors to them. So a person who comes in who has never shown signs or symptoms of abuse before, this screening tool is effective in uncovering possible risk factors. And so the way that it works is that you ask the patient these questions. How often does your partner physically hurt you, insult or talk down to you, threaten you with harm, scream or curse at you, or force you to do sexual acts that you are not comfortable with? And you give them the response options: never, rarely, sometimes, fairly often, and frequently. And then those numbers 1, 2, 3, 4, and 5 correlate to how you score the screening. And the possible range is between 4 and 20. So if you answer never 4 times, you still have a score of 4. A score of greater than 10 is considered positive for risk of intimate partner violence. So if they say, you know, rarely, sometimes, rarely, sometimes, that even though those answers are not glaringly, you know, they're not saying this is every day or anything like that, 2 rarelys and 2 sometimes equal a 10. And that means that they have, it's considered that they've screened positive. And so if you were using the screening at that point, you would find out what your resource is or what the intervention is available to offer to the person. This is another example of just a brief partner violence screen that can be used in a healthcare setting. And you can see this one's a little bit different because they are closed-ended questions, but you're not scoring on a grid, so it's a little bit more open to interpretation. And so you would want to make sure that you knew if the person said, yes, I've been hit, kicked, or punched within the past year, if so, by whom, and it's a partner, that you would know, you know, what the next step as a healthcare provider that you would take, or if you are a person being screened and being asked these questions, that you know that you are empowered to ask for help or resources, intervention, and safety if you choose to disclose these concerns to your healthcare provider. So I wanted to tell you a little bit more about the intersection of healthcare and domestic violence by talking to you about the Healthcare Coalition Against Domestic Violence. And in Maryland, this is a coalition that brings together experts who work in the healthcare field and with domestic violence to offer support and training on best practices for healthcare providers to respond to abuse and to promote a proactive and effective response to intimate partner violence in the healthcare setting. The coalition is a group, it's led by a steering committee of professionals across Maryland, and their mission is to ensure that anyone who experiences intimate partner violence has access to proactive, effective, and life-saving assistance from their healthcare providers. Many strategic partners of the coalition include other statewide organizations committed to ending domestic violence, and for example, the Center for Healthy Maryland, MedChi, and the Maryland Network Against Domestic Violence. And in order to best serve the clinical and allied professionals that are represented in healthcare, the coalition offers trainings, seminars, workshops, printed educational materials to healthcare providers and people working in the field in order to increase awareness of the health-related consequences of intimate partner violence. And the coalition offers support to healthcare providers on how to identify risk factors and provide details on evidence-based tools of intervention. The Healthcare Coalition offers many different trainings throughout the years, so if this is a topic of interest to you for any reason, please look them up. Trainings of interest that have been extremely popular in recent years include the overlap between domestic violence and other social determinants of health, for example, HIV, or demographically marginalized groups, for example, the LGBTQ plus community and their experience of domestic violence. And so I will just let you know, and I'll repeat it at the end, but the website that you can go to access those trainings, information, and resources is www.healthanddv.org. So going back to the Ask Me 3 format that Donna presented at the beginning of the presentation, I wanted to give an example of how intimate partner violence would fit into this format and how it might be brought up in a healthcare setting. So the statement or the problem might be that a person feels scared when their partner screams at them and threatens to slash their car tires if they leave. And the stress is causing this person problems. They're not sleeping well, and as a result, they're missing work frequently. And so perhaps it was recommended that they go see their primary care physician. They can't sleep and they're calling out and they need doctor's notes to miss work. And so now they're in their doctor's office and this is what they've said. So what is the problem? The problem is that intimate partner violence takes many forms, and it often begins with verbal abuse and threats and can escalate to serious physical injury or homicide. And so the problem is that if it's occurring in any format, we want to know about it early and be able to intervene and offer resources before it progresses to more severe physical injury or even homicide. What do I need to do about it? Talk to your doctor and other supportive professionals or your personal friends and family to come up with a safety plan. Be aware of what crisis resources are available to you and how to access them, and know how to engage the support that you need to end the threat of intimate partner violence that you are facing. It's through forums like these and some of the others that I've mentioned where we try to create a safe space for people to get access to information and education and resources so that you don't have to feel scared to speak up, ask for help, or reach out, or know how a safe way to do that is. And speaking to a healthcare provider privately is a safe space for you to ask these questions and ask for help. And why is it important for me to do this? Because all people deserve a safe and healthy relationship, and you have the right to remain safe from violence. Healthcare professionals can help you accomplish this with advice and resources, some of which we've talked about here today. So with that, I want to just call your attention again to the resources at the bottom. If you need to speak to anybody right now or today, if something I've said has made you have questions about your own safety and your relationship, please reach out to any of these phone numbers. And if you're a healthcare professional who's intrigued by what you heard here today and want to integrate more of what we talked about into your own practice, Again, please check out the website that I mentioned earlier, www.healthandv.org, and reach out to the coalition for training and resources. And so with that, we can start with questions and answers.
Erin, thank you very much for that. And let me remind everyone, if you have a question, please feel free to type it in the Q&A box and we will get to those. There are a few. But Erin, let me say thank you on behalf of everyone listening. I really appreciate how you addressed many audiences, including people who may be involved in intimate partner relationship that's dangerous or concerning at the moment, those who may have been in one previously, and of course for providers who may be wanting to help their patients or others whom they know. So thank you for that. A first question is about the HURT scoring. You said 10 or above is considered significant. What happens next? So if someone scores a 10, what should that person expect to happen after that?
So the person who's being screened, the patient?
Yes.
So the hope is that they're in a healthcare provider's office who understands the significance of screening positive for risk for intimate partner violence, and that healthcare provider would be prepared to ask the next questions, which are, is there something we can help you with today? Are you in danger today? Can I connect you to a resource today or in the future that will help improve your safety? So it's of utmost importance to screen for imminent danger. And so as a person who's screened positive and may not realize that they are in imminent danger, the healthcare provider's responsibility would be to educate that person about why we do these screenings, and it's to uncover factors that contribute to imminent danger and then connect that person to the resources that exist for immediate help. So that could be going to a domestic violence shelter to leave the place where you're staying, where the domestic violence might be occurring. It could be legal options for pressing criminal charges or obtaining a protective order. So the person being screened could expect a responsible connection to resources, essentially.
That's really helpful. And there's a follow-up question that just came in, which says, and you mentioned that pregnancy is a time of high risk, and also at the time of trying to exit the relationship is a time of high risk. So here's a question that's a follow-up, which is, how safe is it to disclose intimate partner violence in a doctor's office? Do they get in contact with the police and help you, or do they just give you information on how to proceed?
That's a good question, because the answer depends on you, what you want, the person, the patient, whether you identify as a victim or survivor or none of the above. This is you, your body, your health, your decision. So intimate partner violence does not come under what we consider a mandated report by healthcare provider. The healthcare provider cannot take your information and give it to anybody else regarding that situation without your consent and approval. So you are perfectly free and within your rights to tell your doctor that you are experiencing intimate partner violence and you don't want them to do anything about it, but you do want help for your injuries, or you want information for next time, so that you remain in control. Now, the patient always has also the option to ask for additional assistance. So if they want the police involved, that's up to the patient. If they want help filing a protective order, then like a program like ours here, the Bridge program has advocates that will go to court with you to help you file for the protective order. Same with House of Ruth. So the most important thing to know is that the person, the patient, is in control. Intimate partner violence is about power and control, and it's the abuser taking the power and controlling the victim. And that's the cycle we want to end. And we, the healthcare community, would not replicate it by then taking power over your situation or taking control of your situation. It's your decision and your right.
Another question, Erin, thanks for that. How does someone who suspects intimate partner violence know how or when to intercede? And what are the risks of doing so? And is it just better to mind your own business?
That's a good question too, because the situations are usually difficult, complex, and scary for everybody involved. And so if you are somebody who notices a friend or family member that you think may be at risk, I would recommend taking some of the resources and information you learned here today and offering that person a safe, private space to talk to you if they want it. And so being honest with your thoughts, which is I learned about intimate partner violence at a community conversation this week, and what I learned made me concerned for you. And I want you to know that I learned how to talk to you about this, which is to respect your privacy and your decisions. And I learned about resources that might be able to help you. And I think that I think that people are often torn between helping someone they care about and minding their own business. And it's a difficult balance to strike because you really want to protect the people that you care about. And you also may be aware that inserting yourself into the situation could create more risk. And so I would say, to whatever degree possible, offering the person privacy and autonomy in the process of approaching them is going to help them let you know what's safest for them.
Some really excellent questions coming in here, and your answers are incredible. So if you inform a healthcare provider while at a hospital and he or she does nothing, what's next? What other alternatives does the person have?
So if you're asking for help at a hospital, keep asking. Advocate for yourself. You're empowered to do so and within your rights and deserve that. If you're at a hospital or doctor's office asking for help and not able to get help, I would recommend reaching out to one of these community resources that we have listed, or your local domestic violence resource center may not be listed here on this slide, but every jurisdiction has a designated domestic violence resource center that may be more capable of responding to your request.
Let me remind everyone, there at the bottom of this screen is a number for UMMC Bridge Program, which is the domestic violence program at the Shock Trauma Center. There are counselors standing by now should you want to speak with someone, and some of these questions suggest to me that maybe someone might. So here's the question, Aaron. Another time when it's really difficult to exit a relationship is when someone has children. And I also, by the way, understand when someone has a pet that they may not want to leave, that may be hard. So here's a question that says, what advice would you have if someone has children and that person is being beaten every day, but they don't want to tell anyone? What advice might you have?
So it does get complicated when children are involved because the laws are a little bit different when it comes to children being exposed to domestic violence. And so that would be a whole separate talk. So what I will say is that there are laws that offer extra protection to children from witnessing domestic violence that comes under child welfare laws. And so a child welfare expert or researching the child welfare position on that would be a good option. And perhaps that person that is being beaten every day isn't aware of the vicarious trauma or the direct trauma that their children are being impacted by, and isn't aware that there is additional protection under the law for children in those situations. And that piece of education might be the piece that empowers them to choose a different path. And so without knowing the specifics, I would just encourage that person to look into resources that are also there for children who are in that situation.
We've mentioned the Bridge program a few times, and here's a question that says, which is a follow-on to my comment that you can call someone now there if you like. Is the Bridge program available to the public as a resource, or does the patient or the client have to already be connected with the University of Maryland Medical Center to access those services?
So yeah, our primary mission is to be in the hospital and to be responding to patients that are on campus. So not just the medical center or shock trauma, but we have a lot of professional schools and other people that come to this academic and medical campus. And so it would be very difficult to rule somebody out. If you haven't been a patient here at some point, I'm sure you have business on campus or something, but we do, when we have capacity, take referrals to help people from the community that haven't been a patient here, because ultimately we hope to meet people before they become a victim of violence that would lead them to a hospitalization. And so however they come to us, we will try to help.
Sometimes this whole thing can be really frustrating for people who are in a situation or witnessing a situation. And someone writes that the criminal justice system is flawed. How can women feel empowered to keep striving for medical or legal help when they've been let down by the system? I know that's a big question. So to the extent that you want or feel you can comment, please do.
Yeah, and yeah, it's a big question, and so frustrating for people who are saying, I am saying that I need help, I am saying I need something, and that the resources don't exist. So when people are in the midst of a crisis connected to intimate partner violence, it can be hard to see the bigger picture or even think about getting involved. But there are many ways to advocate for victims and survivors through getting involved with like the Maryland Network Against Domestic Violence, which is a very strong advocacy group who has presence and influence in Annapolis with regards to laws that are made and the way that resources are directed to help people. So that means money directly to programs and to shelters, and money for legal programs to help people that can't afford legal assistance. So if you are in a place where you have the capacity to participate at that level, there are strong advocacy organizations in Maryland. And if you're still in the midst of an intimate partner relationship and seeking help and trying to get out and meeting resistance, um, please know that you are not alone, and that any one of these resources listed on this slide, there's going to be somebody answer the phone and try to work through what it is that we can help you with today. And my personal advice is to not give up, because we care about you.
Someone asked, we did a session last month, and you were helpful with that on suicide. And someone here asked, is domestic violence like suicide, where people may not feel like they can get help or they want help? Is someone who is watching from the outside required to get them some help?
There are a lot of similarities with prevention and intervention in these two areas. I think a really important one to mention is with suicide and intimate partner violence, people are scared to talk about it because they think just talking about it will make it worse. And it's the opposite. We need to be talking about it. We need to be lifting these questions up that are coming through saying, I can't get help. There aren't resources available, because that's what keeps the work going. And so it's not required that an outsider intervene, but the more people who feel safe to bring these issues up and bring them into the light and say, this is so common, this is so needed, these resources are missing people that desperately need them, the better off the outcomes will be. And so I encourage you, if you are an outsider looking at a situation that you think you could help, is to, like I said earlier, with utmost respect for privacy, approach however you can to say, I've learned about this issue and I'm concerned, and is there a way I can create a safe space to have a conversation with you about it?
Erin, how much is domestic violence or intimate partner violence tied to someone's childhood experiences or adverse childhood experiences? Do we know?
I don't know a specific number, but anecdotally, we do know that people that experience violence or are exposed to violence are more at risk for later in life victimization due to violence or even perpetration due to violence. So patterns of disparity tend to transcend generations. And so, that being said, if somebody has had a lot of exposure to violence in any form, then it will be more likely to persist throughout their life and into the next generation: exposure, perpetration, victimization. And adverse childhood experiences make somebody more likely to suffer an early death for any reason. And so an adverse childhood experience not related to violence can still result in early death due to violence. So the connection is very important as well.
That's frightening. And we have a related question here. It says, in the objective of ending the cycle of IPV, would you agree that the cycle is destined to keep regenerating itself, keep recurring, if greater attention is directed toward managing or even hindering repercussions rather than treating the actual individual committing the abuse? I think maybe we mean the other. In other words, how do we get rid of that? How do we stop this? Is it better to go individual by individual or in a more global span to try to stop the recurrence?
I think we need all hands on deck. We I do believe that there needs to be focus paid towards the people who perpetrate violence, in order to end the cycle. But that doesn't mean that we take resources away from people, from victim services. And I think that we need all the systems that are intervening: healthcare, criminal justice, public health, to work together in a concerted effort with an integrated approach, so that we're not working in silos. I think it's possible to work towards a future without violence if everybody in their respective field recognizes how violence presents as a disease, and that there are many different pathways into curing a disease, not just one approach. So we need multidisciplinary and to look at all the factors that contribute to the cycle.
There's one final question here, which says, I work with some clients who are not insured. What are the costs? Are the services only for people with insurance, or are there ways that people without insurance might be able to get help?
That's a great question to even highlight that if you're not accessing resources through the healthcare system, that these community resources are free. And our resources, even as a hospital-based program, are free. And this is part of the result of the work of big coalitions that get grant funding directed to our state and to our local resources to keep these programs operating and free of charge to anybody that needs them. So health insurance aside, if somebody needs healthcare, that could be a barrier, but there's no barrier to calling one of these numbers listed and saying, my insurance status is not important in this case. I need help for domestic violence.
Actually, two more items here. One is just a comment that says the source of the domestic violence issue is not being focused on enough, and that's the problem. And you've said it's evolved over time, and more healthcare professionals are becoming knowledgeable about this issue as a healthcare issue and more routinely screening people for information. That's really helpful. And then another question. Oh, they're popping in now. How can the legal system actually claim interest in reducing or even preventing incidents of DV if, by definition, greater attention is directed towards the physical aspects of abuse as the more acknowledged standard of abuse, when everyone knows emotional is just as important and just as insidious?
Yeah, that's a tough one, and I'm certainly not a legal expert, but I can say that there are very high-level legal experts in the field that work to educate lawyers about how to prosecute cases without having the victim testify so that the victim can be more protective, how to prosecute people that continue to abuse from even within jail, and how to really understand the hidden signs and symptoms of domestic violence that can become very fatal, so that we are not in the situation where a homicide is the crime that's being prosecuted. So there are a lot of great legal minds that work on the prevention aspect of domestic violence as well, and I know that work is happening.
Thank you. Erin, let me thank you again for such a complete discussion, reaching so many in our audience who may find themselves in different circumstances. The last comment here is, could this lecture be recorded in order to be reviewed again? So let me tell you, everyone, how you can find this. This session was recorded, it's probably on the next slide, and will be available to view in about 48 hours. You can go to www.ums.org/Let's Talk, which is the name of this series, Let's Talk. Do we have another slide there, Erin?
Yes, about
there
next month. Yeah.
Yes. So, well, it's okay. There's the website for you, www.ums.org/Let's Talk. And there you can see any of the prior sessions that we have done on our third Wednesday, all of those. And next month, is it up there? Next month, we'll be talking about Alzheimer's and dementia, again on the third Wednesday, which will be November 17th. So the slides will also be available to you on that website that I've given, and you can re-review this session. And it will remain up there for quite some time, so you can look at it as many times as you might like. Erin, once again, thank you so much for your expertise and for sharing so willingly. Everyone have a wonderful day, and please do stay safe. Thank you all.